got Julie Logue here. Julie's a specialist diabetic midwife at Whittington Health Trust, and you're the current lead midwife for diabetes care, aren't you there? And this is a service that Julie actually set up herself from scratch, and that was in 2003, so you've been going quite a while, haven't you? Yeah. Where anyway, it was then in 2003, it was recognised by the multi-professional team that women with diabetes needed a named midwife. I think I'm all sure we're in agreement with that, aren't we? Since then, she's been involved with the Royal College of Midwives in defining the role of the lead midwife in diabetes and developing the job description. As over the years, these roles have developed, but there was no kind of common standards for midwives for this specific role. So Julie now works with obstetric consultants, the diabetic nurse and dietitian, and that's, you know, to help review the services at the Whittington. The hospital has a weekly combined clinic, and she also runs daily midwifery clinics to see women to follow up. She participates in the pre-conception group sessions run as a team. She and her team also participate in the National Diabetes in Pregnancy Audit run nationally and to complete data collection. You're really busy, but we're looking forward to hearing what you've got to say.
Yep. Sorry, that's a bit high for me. Is that okay? Yeah. Okay, so I'm actually going to present some of the audit data from the national audit, just to show you, what data they're collecting and, where we are really with women with pre-existing diabetes. And then I'll just talk a little bit about our screening for gestational diabetes. But the national audit focuses only on women with pre-existing diabetes. There was an audit done in 2003 by CMATCH, as it was then. As you know, there's no CMATCH now. And that, again, was a national audit, and it looked at standards of care. And it's really looking at us and how we provide care, not looking at the women themselves. So in 2003, they didn't need consent for this audit, even though there was data collected on women. But this national audit now that started in 2014 and is now ongoing all the time, so it's not going to be just a snapshot, it will be audited all the time. That audit, women do need to give consent because it's on a database and their NHS number is held centrally. So there was a lot of arguing over audit and research, but they have decided that they actually should ask women for consent. So we do occasionally have women that refuse to participate in that audit, but most women are happy to. So, oh, sorry, I don't do that. I do that. I beg your pardon. The audit standards, however, they're measuring them now against the NICE guideline. So rather than going back to the standards of CMATCH, because CMATCH actually collected, so much data when they did that in 2003, and I don't think it's viable for them to try and collect that amount of data anymore. So this is actually measured against the NICE guideline for diabetes in pregnancy. A lot of it you'll see does cover both things. So looking at the pre-pregnancy, we're very, very passionate about trying to catch women with diabetes before they get pregnant to do pre-conceptual care. In 2003, the CMATCH audit showed it was one of our biggest failings, that we just do not catch enough women. And unfortunately, in 2015, on the latest audit, we're still not doing very well with that. So it's a bit of a shame. Basically, we want to look at things like folic acid use. Women with diabetes should be on a higher dose of folic acid than women without diabetes. Their blood sugar control. So this is really important. The level of blood sugars at the time of conception directly linked to the risks of having either a baby with an abnormality or some complication in the pregnancy, like stillbirth. So women that conceive with uncontrolled diabetes have a much higher chance of having problems. We want the HbA1c. Do you all know what that is? That's the average blood sugar. We're now measuring it in millimoles per mole. I know it in percentages, but I will do the correct thing and I'll talk about it in millimoles per mole. But we want it to be under 48 millimoles per mole, which in percentages is about 6.5% before they get pregnant. So if you've got a lady with type 1 diabetes and you tell her that pre-pregnancy, they'll freak out quite a lot because that's very tight control. We accept, if it's under 7%, we still think that's quite good. We've had women conceiving with HbA1cs of 14, 15%, and that's really quite scary. But, our goal is to try and get it down as much as possible. We also want to look preconceptually at all the other medication they're taking. many diabetic tablets are harmful to the baby. We only use in pregnancy metformin or insulin, and that's kind of it. So if you see a woman in a practice or in the hospital clinic that's on lots of cholesterol-lowering drugs or tablets for diabetes that, you know, are contraindicated, we need to change that. Often over to insulin, unfortunately, because sometimes the metformin isn't enough, but then we need to review all of that. So all of this is ideal before pregnancy, and as I said, statins for cholesterol, ACE inhibitors and ARBs, which are all for blood pressure, we need to try and review those and get them onto tablets that are safe to take in pregnancy. So if we don't see them, we don't do any of that. So that's a shame. During pregnancy, our goal is to see them before 8 weeks. So this is a really important target. As we said, looking at the HbA1c as soon as possible, pre-pregnancy ideally, but as soon as they get pregnant, see what the level is. It helps us to know what to tell them about the risks in the pregnancy. And eye screening, very important. Women with pre-existing diabetes, if they've got underlying eye problems, are likely to worsen in pregnancy. It's something that they need to know. We can do things about it. At the Whittington, we had one woman we had to deliver at 32 weeks, so she could go to have eye surgery. So it was very dramatic because she was bleeding at the back of the eyes. Very rare it's that bad, but it can happen, so we need to know about that. And then birth and neonatal care. So one of the things CMAT showed, many hospitals had a routine policy of admitting all babies to special care or neonatal unit just because the mother was diabetic. So the CMAT recommended very strongly that we should be aiming to keep mother and baby together. We've never done that at the Whittington, but you know, neonatal admission is still high, but it's always based on the clinical need. And then the elective and timing of birth. This is a difficult one. We know from CMAT the caesarean section rate among women with pre-existing diabetes was around 67%. So you can imagine, if you're telling a woman this before she gets pregnant, it's a bit scary. That, unfortunately, is now about 65%, so it hasn't really come down. We still deliver women earlier. We deliver women for lots of different reasons, but macrosomia per se is one of the things we're trying to not just deliver women because the baby's big. But these women are at risk of preeclampsia, kidney problems, eye problems, and so their delivery is often earlier than it should be. However, we shouldn't routinely admit babies to neonatal unit. So the key findings so 2015 it's reported, but of course it's the 2014 data that we're looking at. There was just over 3,000 pregnancies. Not all hospitals have to participate in this audit, so there's 155 units that do, and there was 10 new units last year, but it's not compulsory that we submit data. And of those women with pre-existing, about 46% had type 2, and there's a massive variation in hospitals of what's the type of diabetes that they have. So in some areas, over 70% of the women had type 2 diabetes. Now, when I started nursing and midwifery, I don't know about you guys, you didn't see a woman with type 2 diabetes in an antenatal clinic. They didn't get pregnant because it was always older women. You know, I looked after a girl last year who was 20 years old and had type 2 for 4 years. So, you know, it's awful. Associated with obesity, she'd had gastric surgery, she'd lost weight, but she'd still had 4 years of being diabetic before that. So that's really sad. But years ago, we never saw these women in a clinic. So, and you know, varying on different regions, the numbers are very high. Still, women with type 2 tend to be older and tend to live in areas of social deprivation. Large variation in what we provide in services. Some of that I think is justifiable because I think depending on where you are in the country, you'll have more people with diabetes, but there is massive variation in what we provide. So what, you know, NICE recommend, as we talked about, the pregnancy preparation, the early contact, and minimising neonatal admissions. So, against the NICE guideline, we were marked, and only 16% of women with type 1 and 38% of women with type 2 had good control at the time of conception. So that's really poor. This is very similar to how it was in 2003. So when you think 14 years later, we're still doing the same thing. It's a bit of a shame. Only 46% of those with type 1 and 23% of those with type 2 were on 5 milligrams of folic acid. Prior to pregnancy, this is. And women with type 1 from deprived areas were much less likely to be taking folic acid. So there's a lot of things that are similar for things like obesity, smoking. There's a lot of links to social deprivation as well. But as I said earlier, so the risk is associated with poor control. So we've got to try and get it out there to the women that having good control at the time of pregnancy is so important before they get pregnant. And the majority of women didn't have contact before 8 weeks of pregnancy, so that's also feels like we're not doing the right thing. Hypoglycemia was one of the other things that NICE measure. So these are people that need treatment in hospital for hypoglycemia. So lots of people on insulin obviously have some low sugars. If they can self-treat it, of course, that's fine. But these, showed 1 in 10 women with type 1 diabetes had admission to hospital for it was that severe. The other message that we want to do pre-conceptually that they don't measure in this, but is talking to women about hypoglycemia early. Because in the first 10 weeks of pregnancy, often their awareness changes. This is physiological, it's pregnancy hormones, but they could test a blood sugar and find it's 1 and feel absolutely fine. And that's a bit scary because they could go out and drive. And one of the maternal deaths in the, not last 3 years, but the 3 years before, was a type 1 diabetic that had a hypo driving. So these are things we must get across to say, your signs might change in that first 10 weeks. And if we're not seeing her for the first 10 weeks, she's not going to know that. So they don't measure that, but that's really important. And as I said, 66% of women had a caesarean section and 56% of women with type 2. That's shockingly high. If you try and talk to a woman who just wants a section first baby, who's got type 1 diabetes, and you say, oh, well, you don't want to just do a section. If she comes back at you saying, I've got a 70% chance nearly of a section, it's hard to talk her out of it. And we've had a couple of women with that sort of request, and it is a bit hard, to defend it. So. The only good thing that came out of this is that in the last 10 years or so, we've reduced the stillbirth rate. That is really great, because in the 10 years prior to that, the stillbirth rate had not moved. And we're doing all these things, and we work so hard, and we all try, and you feel really like you failed when something doesn't work. It is still high. It is still at least 3 times higher than women without diabetes. So we can't say there's no risk, but we have reduced it quite a lot. Sadly, we had a type 2 diabetic with a stillbirth last year. It's always awful when it happens. And this awful thing was she had really good control when she conceived, and all through the pregnancy, she had great control. So, of course, we say it's the diabetes because we can't find any other reason, but actually, she wasn't somebody that we were thinking would have a bad outcome, and came in to clinic to see me, and there was no fetal heart at 38 weeks. I'll talk about delivery timing, because now that's nice, have slightly changed that as well. But, we wouldn't have delivered her before 38 weeks because she was well controlled. So, again, you feel this is another failure. However, preterm delivery and macrosomia, we're still delivering women a lot, earlier than what we need is individual data, because some of it is justified. It should only be a clinical reason. If the baby's not growing, if she's got high blood pressure, we have no choice. We have to deliver the baby, but we need to look at the macrosomia in more detail. So, I just forgot to say the last bit there. I don't know how to go back. But if the HbA1c improved by 24 weeks, there was much less risk of macrosomia. So there was a direct link to her improving her control during the pregnancy. So that was a positive thing. So we could be a bit assured to say, look, if it does get better, and most women, even if they start off with very poor control, by the end of pregnancy are just amazing at how they get it under control. So, around the 24-week mark seems to be important, that if it's better then, we can be a little bit more relaxed. I think we can carry on till full term. So the recommendations come out of this, and the other thing I always say to women when I'm consenting them for this audit is to tell them that they're auditing the service. They're not auditing her blood sugar control, because people get really freaked out about that. If they've got bad control diabetes, they don't want it on any paper anyway. But they're auditing our service. And so the recommendations will come out of what we are going to do to make this better. So they want us to do much more pre-conceptual counselling. If anyone has any ideas about how we can improve this, we do try lots of different things. We run some classes several times a year. We have a slot in every clinic to do pre-conceptual counselling. But that information needs to be out there for women. The general clinic in the Whittington have a database of all the people seen in their clinic. So we send the invites out to everybody on that database. We send out about 100 every time we do a class. Thank God they don't all turn up, because the room isn't big enough. But usually we get about 6. So you kind of think, okay, it's always very positively reviewed. The women really like the class. However, there's not very many people coming through it. Also, that's only on our database. So all the type 2s that are looked after by the GPs, and some type 1s we're not getting those women. We've written to the GPs to tell them about what we're doing. It's just hard work. One of my colleagues up in the Wirral, I think she also has a family planning course. So she bases herself once a month in the juvenile diabetic clinic so that she can talk to teenagers, because that's where you need to start the message. Not that they need to come for formal counselling then, but if they're thinking of a pregnancy, please come and see us, you know. So even if it's 5 years down the line, they might remember it. So there's other things with pharmacies we've tried in Bournemouth, giving leaflets to pharmacists to say when someone collects their medication, could you give out a leaflet just to say if you're thinking of a pregnancy, can contact your local hospital with the details on. And that was quite successful, but they're quite intensive work, as you can imagine, to get all the pharmacists on board. And I don't know if we'd be able to manage that in London. It's quite hard. So getting the information out there, we can run all the services we want to, but if nobody comes, then there's not very much point. Tailoring the approach to try and offer the women at the right time. If you send out letters to all of the women on our database, some of them are going to get really irritated, and I have had a few phone calls saying, please don't send me any more invites, I'm not interested in this, and that's fine. So it's really trying to not do that. On the checklist they have as well in our diabetic clinic, not in the antenatal clinic, the general one, they have a little section that says, have you discussed pregnancy? So again, it just reminds the doctor that's doing the annual review just to either say yes or no or not applicable, but it's not great. And telling women to use contraception if their diabetes isn't well controlled. I mean, it's that simple. Please don't try yet. Let's get your diabetes under control, and then, you know, let's see how we get on. Improving how do the women access our services. So this varies throughout the country, and I imagine different hospitals. We have self-referrals. Women can do it online. They can bring in some paper. They can phone me. They can email me. There's lots of ways they can access it, but again, they need to know that. So it's getting that information on the website and getting it out there so women know how to access the service. They do not need to go through their GP. However, that will vary. One of my ladies moved from us and moved up to Luton or Milton Keynes, and they absolutely wouldn't take a referral from me, from anyone. The woman had to find a GP in the area, wouldn't take a self-referral. So, you know, she's on insulin and everything. I had to keep looking after her until she finally found a GP. So that's a bit mad, but things are different everywhere. We need to get the information out there as to how they access us. And we need to try and improve that blood sugar control in pregnancy as safely as you can. Somebody with type 1 diabetes is not going to get their HbA1c down from 13% to 7% in 2 weeks. You need to be realistic, otherwise she'll be overdosing on insulin. We need to tell them if it is high, we'll try and get it down in the next couple of months. It needs to come down safely, because hypoglycemia, as we said, could be dangerous. Most of our women... I'll come back to that, sorry. Okay, so this is recommendations now for the diabetic team. So these are the people that see patients with diabetes. And primary care, family planning and community teams. So these are people we really need to talk to. If you've got a population of women that have got diabetes, it's trying to say to them, again in those clinics when you're doing their reviews, if you get pregnant, this is what you need to do. We need to get you under good control. We might need to change your medication. Talking to them about pregnancy. They keep a register of all diabetics, but we've found such problems in North London with some GPs are great, some only maybe have one woman on their books, so they're not going to be as proactive, and we found it really difficult to get everybody on board. But it's getting them to refer in as soon as possible. They do a letter, it goes to all over the world, and I get the letter when she's 12 weeks, and it's just hopeless. So sometimes you feel really frustrated. And getting it out to the GPs to say, this is how you refer a woman. We had an open day at the Whittington about 2 months ago, and we have a project I will just mention to you, because somebody was doing something today about normal birth, so this kind of ties into that. So the open day was there, and I was there with my stand, and 2 people came to talk to me about diabetes, and they all went to the natural birth thing, and I was like, okay, fine, but I want you GPs to come and see this as well. So it was really frustrating, but we were trying to get the message out there to the GPs as well, but they kind of wanted to focus on the natural birth project, which is fine too. And then our services, really for us to focus on how are we going to move things forward. So we are again now going to write to all the GPs in our area, which is a lot, to say to them about what services we provide, to say if you've got a pregnant woman or a woman that's thinking of getting pregnant, please just refer her in and we will get her in quickly to see someone and talk about her diabetes. So we're going to try again. And our diabetic consultant takes the lead on a lot of these things because she has access to the diabetes database from the general clinic. So that's all about the pre-pregnancy audit. This is all online, so you can just type in on Google diabetes and pregnancy national audit. It just comes up there. So I haven't plagiarised anything. This is all their stuff. There's loads of bits that go with this, with graphs and everything else, to sort of show you the variation in populations and things. So please do look at it, because it is interesting information. as I said, the one thing we needed to get across from CMATCH 10 years ago is that there is no difference in outcome for women with type 1 or type 2 diabetes. We've always had it in our head that type 1 is so risky and dangerous. Actually, the risks were the same with both women. So there is no difference for their risk of having a stillbirth, having congenital abnormalities. Type 2 diabetes is just as bad. The other thing, if you're seeing women and talking to them, is how long they've had diabetes. Because if they've had diabetes a long time, the risk of complications are higher. So they may have had diabetes since the age of 4, but they're only 20. But actually, they've still got lots of diabetic complications that makes the pregnancy more difficult for them. So it's just to bear in mind there's no different in risk. And we mustn't say to women, if you've got type 2, it's only mild diabetes, because it doesn't really work that way. And just to say, they're looking at only pre-existing, but there are some other types of diabetes like MODY, this mature onset diabetes of the young. They will be included in the study, but they're much rarer, so it's usually type 1 and type 2. Women that we pick up in early pregnancy at the Whittington with high blood sugars, we don't put them into this audit because they weren't diagnosed, and you're going to skew the figures because they won't have had pre-conceptual care because they didn't know. So you just have to be careful you don't put the wrong women in. By the end of pregnancy, I get confused. So does anyone have any questions about pre-existing diabetes? And then I'll just talk about gestational. Sorry, I'll just get my water. It all sounds a bit pessimistic, I know. But we have reduced the stillbirth rate, so that's good news. Anyone, any questions? I was just going to cover the gestational diabetes. At the Whittington, the majority of our women are gestational diabetics. It varies in different areas. I don't know if any of you work in Newham or the Royal London, because their population is more type 2 diabetes. So, our care has to reflect your local population. So I will see most women with GDM. We have probably about, not even a third of our women will have type 1 and type 2, but I believe that your clinic has got some like 80 women going through it every week or something crazy like that. So it varies with different populations, and the screening, unfortunately, the screening varies as well. So, I've assessed the risk. So NICE published a guideline for screening in 2015. And I don't know how many units have gone over to use the NICE guideline. We use some of it, and we use a slight variation as well. And I'll come on to it in a minute, actually, as exactly what I do. I haven't put it on here. I've only done NICE. But we actually do screen slightly differently. However, these are the risk factors that NICE recommend. It's interesting that NICE count macrosomia as over 4.5. And actually, when they did the national pregnancy audit, they're counting macrosomia as a baby over 4 kilos. So I don't know why there's a variation there. But this is what NICE recommend. Some places screen women who have polycystic ovary syndrome. NICE aren't recommending that. There is a link with impaired glucose tolerance, but it may be not strong enough to, be cost effective. Previous stillbirth, we do actually screen our previous stillbirth still. I'm not sure of the evidence there, but this is what NICE recommend. The other thing we have to be careful of is we're not just doing a random blood sugar to diagnose diabetes. It hasn't been valid for quite a long time. So it's the glucose tolerance test is the gold standard. Most of us, I think, are doing the 2-hour 75-gram glucose tolerance test. We are doing, I think most of us now are, but we're not doing screening everybody. We did do that for a long time. We're doing risk factor screening, which is, I think, slightly more cost effective, although in some areas you're still screening most of your women because we have a lot of risk factors. Women who have previous GDM, these are the only ones that we pull out of that, and they can either come and see me and we just start blood sugar monitoring. But the only downside of that is they have to do it through the whole pregnancy, whereas if they do a GTT and it's negative, they don't have to keep testing. But I would talk to the woman and offer her whatever she wanted, really. But you can do the glucose tolerance test now any time after booking, so you don't have to wait till 16 weeks. So these women should have an early GTT. Depending on how sick they are, because actually that glucose makes people sick. So at 9 weeks, it may not be appropriate to do it. Every other woman should have a GTT between 24 and 28 weeks, so later on in the pregnancy. The variation that we do at the Whittington is we do a fasting blood sugar on women with risk factors early in the pregnancy. And the reason for that is that we seem to have statistically a slightly higher proportion of picking up women with type 2 diabetes undiagnosed at the beginning of pregnancy. I imagine at Newham and that you couldn't do that because you'd be picking up another 1,000 women. So, well, we do that, and we have about 5% of our women we pick up with high blood sugars early in pregnancy. So I saw a woman on Wednesday who had her fasting done last week, and it was 5.8. That reaches our criteria. She started testing, and all of her sugars are really high. She's only 10 weeks. She's not even had a dating scan yet. So she will almost certainly have type 2 diabetes. But at the moment, we just have to treat what we see, and you don't diagnose it in pregnancy. You have to do a test outside of pregnancy. But obviously, she's quite devastated to have this so early on in the pregnancy. So that's what we do. So this is what NICE say the cutoff should be. So we don't use this cutoff. So, and I've just realised Basildon don't use it, so I'm pleased to see that. UCH don't use this. So this is what the NICE have recommended. We use the international, I can never remember, International American Diabetes Association guideline, which is actually the gold standard test. And we use 5.1, so 5.1 or over, 10 or over, and 8.5 or over as the diagnosis. So we use 3-point GTT. Again, it's always very difficult because it's NICE, of course, have to look at the cost. And again, if your hospital has a lot of type 2 diabetics and you start putting the figures down a bit, you're going to diagnose a lot more and the service won't be able to cope. So I'm not going to say what's the best thing to do. I'm just saying this is what we're doing at the moment. And one of the things that we really need to talk to women about, and really before they do that GTT, is to tell them what it's about, what will happen if they're diagnosed with diabetes. I can't tell you how many women come to me hysterical because they can't go to our birth centre. Unfortunately, our birth centre, we have a policy, they can't go there if they've got any complications, even if they're diet controlled. So they get really upset over that. And, you know, sometimes it's really difficult because they didn't know this was going to happen. So I think we've devised a leaflet. It's still trying to go through our people that read all leaflet committee, but you've just given me a great leaflet I'm going to look at as well for women. So, you know, it's just getting the information there so women know what they're going for and understand what the test, if it shows positive, will mean. Many women do fine on diet. You know, you would, I think if they do really well with no treatment at all, you would think, is it a false positive? But a lot of women can change their diet quite drastically and actually keep them under control. But the majority will need some form of treatment. So we do the same things. They come to the same clinic with us as the people with type 1 and type 2. They see the dietitian who will talk in great detail about their diet. Now, I always start it off with a general discussion about healthy eating, but the dietitian will go through their diet with them in a lot of detail. And actually, she's normally the person that comes back and says to me, that woman needs treatment, that woman needs more time, because actually she's the one that can tell better. So, you know, which is such an important part of the team. And we just, as I said, for the other ladies, we use metformin or insulin, and that is it. So it's a bit scary, because if you start off, if you have diabetes outside of pregnancy, there's so many drugs that can be used to help you before you start insulin. Whereas GDM, you know, you could be on insulin at 24 weeks. So it's a bit scary, and people worry that they're going to be on it for life and things, but they wouldn't be. But, you know, it's a bit frightening. And the main risks with gestational diabetes picked up after 24 weeks is the mechanical things of the large baby, difficult birth, neonatal hypoglycemia. And they're the big three things. The HAPO study, this hyperglycemia and adverse pregnancy outcome study, that was a worldwide study and had a lot of women in it. You can look that up again online. It's got great data in it. Showed there was no association with stillbirth and gestational diabetes that was well controlled. We still hear women, and they look it up online, and it always talks about stillbirth, and it's really frightening. But if their sugars are well controlled and baby's growing normally, there doesn't seem to be a link with stillbirth. However, you have to be a little careful, because the woman that we've just picked up this week with the high sugars, I would have a different conversation with her and tell her I don't know what her risk is actually, because we don't know if she's got type 2. We don't know, you know, what the outcome might be. So we would manage her in the pregnancy as though she's pre-existing, as in advice on delivery and everything, which will come up to timing of delivery. But, you know, it is, some women fall into a very grey area. And in the big studies, if the sugars were high, they are taken out of the study. You have to acknowledge that, because they couldn't ethically leave somebody in the study with uncontrolled blood sugars. So the study can only reassure us on the women with good control. One of my biggest things I spend so much time doing, and we're looking into doing group sessions for this, is teaching women to monitor their blood sugars. That wasn't me. So this is our first visit after the GTT, and we go through, explain how to use the machine, target blood sugars, basic diet information. We get them back then into our clinic, and that's when they'll see the dietitian, normally only once, but the dietitian's there every week, and if a woman wants to see her, she can see her again, but most people it's a one-off visit. And We talk about exercise as well that they can do, find out what they normally do, how active they normally are, but even walking and swimming is really good and helps keep down the blood sugars. And regular exercise, yeah. I said all that. So I would never start somebody on metformin before they've had a chance to adjust their diet. I know some units see them for monitoring and start on metformin the same day, and I think that's a bit unfair because we have quite a lot of women that will do really well. And metformin itself has some gastric side effects, so you don't put everybody on it. So we always give them at least 10 days to 2 weeks to monitor their sugars, come back and see us in the clinic, and then we can have a look at everything. And the biggest question to ask is, can you do any more with your diet? Because some people, just can't change anymore because they actually eat quite healthy already, and they're not there to try and lose weight, and they're not there to not have any carbohydrates. That's really not what we want them to do. But other women can know that they can change their diet quite a lot. We had a young girl on labour ward the other day, and she's on insulin, and she's drinking Coke. And they're ringing me to go down and tell her off. And I'm like, can't you tell her not to drink it? She's going to drink it. She's 20 years old. She's not listening. So I went down to have a chat and say to her, I'm never going to get you off this trip if you don't stop drinking Coke. Some people, you're never going to get them to comply. And we have to kind of, I don't know what we do with those ladies. But anyway, they delivered her. So that was the answer to that one. But yeah, so some people won't listen to anything we say and other people will. So we have to tailor it individually. And as I said, we use metformin in the first instance. If they can't tolerate metformin, we may have to go in with insulin straight away. We are not using, I think glibenclamide comes up on here next, but at the moment, we haven't really started using that. It has now been said by NICE it's safe to use, and we probably will start using it for women that don't tolerate metformin, but at the moment, those are the two that we're using. And as I said, a woman that has high fasting blood sugars of over 7 in very early pregnancy almost certainly has pre-existing diabetes, and we need to jump on that very quickly. And that just talks about the different sugar levels. Right, so glibenclamide, as I said, it has slightly less gastric side effects, so it might be more tolerable to women, but it's just been used for a sort of shorter time. It's also important to tell the ladies that none of these drugs are licensed for pregnancy, and when they get the metformin, it says it on there, do not use in pregnancy unless medical advice, so they get really worried, and they're not licensed. I think trying to get a license for a drug in this country is very difficult, so even insulin is not licensed for pregnancy, so it's important that they know that it's not licensed, but they've done a lot of studies to show, that they haven't got effects on the baby. And in actual fact, it's the blood sugars being high that have the effect on the fetus. Constantly, that's always the problem. So, but they will question that and say it's not safe to take. And the other thing that's really important that we miss sometimes is just postnatal care for GDM ladies. Years ago, they used to think that GDM was a bit of a fallacy and we shouldn't be worrying about it. The big studies, the HAPO study and the A-Choice study showed that actually we can do something to improve outcomes for these babies. And the other thing is there is a link with type 2 diabetes. There's no doubt about it. Depending on the study, but about 30% of women at least, and I think NICE said up to 50%, will develop type 2 diabetes in the next 10 years. And you can help them either avoid that or reduce their risks by being tested frequently. One of the things I always tell women is that type 2 diabetes has a very insidious onset. It's not something where you'll wake up feeling sick the next day. So most people are diagnosed, they've had it for about 10 years before it's picked up. Then they'll go and often have an eye check and see some problems, or blood pressure will be high and someone does a sugar test. By that time, the sugars have been high for 10 years. So it's really important that they're tested every year post-delivery on a fasting blood. I don't have to do GTT, just a fasting. If that's high, then the GPs can put in, they've got lots of guidelines in place for managing diabetes. They can put in either treatment or saying start exercising, start trying to monitor your blood sugars more closely. So it is important that we educate them about the fact that type 2 could come on and you will not know about it for a long time, and the only way to improve outcomes is to pick it up quickly. In this country they've just started testing us as we hit 50, so I don't know if anyone's gone over 50, but I got a letter the day I was 50 to say go and have your blood sugar tested. So they are now routinely starting to test, but still 50 is a bit old for our pregnant women. It's just so expensive, and you're going to pick up a lot of people with diabetes that you don't know about. So they are starting now to recognise they need to test. Maybe the age will come down to 40 soon, so we'll see. But that's important to talk to them about over the next couple of years, is trying to get their weight down, exercise, etc., to reduce the risk of developing type 2. I think that's probably the bit we don't do so well. It will depend on the GP surgeries because they're all followed up by GPs. So, but it's important to tell them that. If they get pregnant again, chance of developing diabetes in the next pregnancy, probably about 95%. I've seen a few that have escaped me second time around. If people lose a lot of weight, obviously it can reverse things, but yeah, they have a high chance of having it again. So that's...
with you.
See, I told you I would be on time.
Thank
But I don't know if you have any questions, or do you want to do questions afterwards?
Did anybody have any quick questions there now? It just is amazing what you're doing, which makes us know that you've got to have a specialism here, because it's such an issue, isn't it?
It is an issue, yeah, it is, yeah.
And seeing such a lot of women.
Yeah,
And
yeah.
young women
Yeah.
as well. You know.
And not to undermine the psychological problems that come along with having, especially type 1 diabetes, and they've done a lot of research on depression and behavioural problems in, children. If you develop that as a child, it's a lifelong thing you've got to live with. And I remember a woman saying to me who had thalassemia major, so she had 2 major conditions. She said she'd rather have thalassemia than diabetes. And that made me go back, because I thought, God, thalassemia is an awful disease. But in her mind, she could cope with that. She couldn't cope with being diabetic, and that's really sad. So, don't underestimate how the psychological problems people have, because it's not a matter of just get under control and that's it. It's not that simple. It's a complex condition. So, we need to be there for their, sometimes just to listen to them. Sometimes that's all I do. I might have a whole appointment where I don't do anything, but listen and let them go and think, oh my God, So it is important to acknowledge that it's not an easy condition, except for the naughty ones that drink Coke all the time. That's a different thing.
Thank you.
Thank you.